Okay. Okay. We will now go to something completely different. This 30-year-old man, a little bit overweight, but it seems he is quite happy. He doesn't suffer. So why should we do any treatment on him? Of course, because the wife is suffering. But the suffering is due to the snoring, and that is something which happens from time to time. And the symptoms he tells us why he came is the typical series of symptoms with a dry throat, and in the relationship, his wife is disturbed in her sleep because he is snoring, and he has a blocked nose mainly in the morning. Any other conditions, drugs, no diseases known, no drugs. So it seems that this is something which goes along with his happy face, at least regarding himself. And there's no daytime sleepiness. And we were focusing in the noon session that sleepiness is an important factor for patients and for giving us a reason why we should treat them. So he has no daytime sleepiness. Everybody is aware of what the ESS values are and what it is. So 10 is considered to be still normal daytime sleepiness. Some situations you would have some likelihood to fall asleep, but not all the time and not in every situation. So, and he didn't complain of any falling asleep, any problems falling asleep or staying asleep. And he said, well, I don't have any problems. For the examinations, the septum was median, the turbinates were hypoplastic, rhinomanometry was, as you can see, reduced in both sides, and there was some positive allergy testing to dust mite, and only 0.5 centimeters of maximal mandibular advancement, so he couldn't advance his jaw well. So what would you do next? I mean, it seems to be obstructive sleep apnea or just simple snoring. Who would go for, according to the information we have, who would go for simple snoring? Who would go for obstructive sleep apnea? Who says, I don't know? Well, what would you do next? Would you go for treatment? Would you go for other diagnostic procedures? I mean, that's a typical case. You will see them many times. They come for snoring. You have no information pointing really to obstructive sleep apnea. No daytime sleepiness, no hypertension, no witnessed apneas. Yes?
I would still do the sleep test.
You would do a sleep test, a simple out-of-center testing, 6-7 channel device. Anybody would go for polysomnography in that case and says that is something we have to do. Olivier, why would you go for polysomnography?
I think that in particular, probably based on some literature, that in the cases that you don't expect to be yes or no to have a severe sleep apnea, that you need to do it.
No daytime sleepiness, no hypertension.
There is loud snoring, and this warrants, for me, it warrants a full night, full sleep test.
Would he be happy if we administer CPAP? We don't know, of course, but
you never know.
That's something.
But no,
okay.
not in terms of getting him to CPAP, but in terms of not missing any diagnosis. Yeah.
There was a remark and another one there.
Why not go for a month of trial of intranasal corticosteroids?
Mm-hmm. That's a good alternative. We could discuss about, do you go for further diagnostic, or he has a clear nasal problem? Why not go for nasal treatment first? Maria, you had a comment?
Subjective perception, but it is subjectively, like my grandfather's know, my mother's snoring, that people just basically say, well, and they don't have any reference book. So I think that usually we suggest that we do a sleep study for diagnosis. Or do any kind of diagnosis. Because you don't want to make diagnosis.
So, I mean, I think I'd agree with most of the comments that have been said, but allergic rhinitis, I mean, there's no harm in treating that because there's so much evidence that if you treat that, the sleep quality improves. I'd also think the point that Olivier mentioned, some people are very stoic and they might have sleep apnea, but they don't feel sleepy. So I do understand where Olivier is coming from, but personally, I would have treated the allergic rhinitis with avoidance of allergens, antihistamines, and intranasal steroid for 4 weeks. They come back, they say, well, I'm different. And you have your
that's why we took that case, because I think you can do both. And it depends on what, maybe some additional information you have, and also according to the wish of the patient. If that patient suffers from his nasal problem, then you can do a treatment right away. But if he is really only coming for snoring, but the nasal problem, you have the rhinomanometry, but he doesn't really suffer from it, and he doesn't know whether he should do some treatment on the nose or not, then an additional diagnostic procedure would help to know where the way should go. So, but that's a typical case where I think you can do both without doing a wrong thing. So the soft palate looked like that. Yes.
You say that this patient has got a dry mouth in the morning, right?
Mm-hmm.
Now, what are we attributing the dry mouth to?
The dry mouth, of course, the question is the dry mouth due to the nasal obstruction and opening the mouth due to that? Or
So, to me, if you're going to take that as a symptom, I think that's a more important symptom than nasal obstruction. Because as far as nasal obstruction goes, a huge proportion of our patients don't really know how well they breathe.
that's
So,
why
to me-
rhinomanometry is there as well. And
So here you have a condition where if you're basing it on the patient's complaint, as there are two complaints here. The patient says, I don't feel a nasal obstruction, but yet you're waking up with a dry mouth, which probably attributes to a blocked nose and you're breathing through your mouth. So we really got to see a comparison between these two symptoms and look at where we're going to place more importance. Are we going to place more importance on the nasal obstruction or the dry mouth in the morning, which I think is very significant? Because a lot of these patients...
the dry mouth can also be in patients where there is no nasal obstruction at all, but by habitual mouth opening, mouth breathing, they have no nasal obstruction, but still they can do it. So that's something we have to discuss with the individual patient. And I think each of the ways we were discussing in this not severely affected patient with almost no other symptoms, no diseases, we have to decide how to start, but we have to tell the patient that there are several things we should add. So that was the finding of the soft palate. Just to show you. And that was then an out-of-center testing with, as you can see, a normal oxygen saturation, a few hypopneas, and some snoring all over the night. There was no supine position in that particular night. And then you see no apneas, only hypopneas. The apnea-hypopnea index 1.6, but some snoring, 81 snores per hour, but I don't believe in the snoring recording capacities of the out-of-center or the polysomnography systems. They are the weakest signals we have, I think. And then oxygen minimum 0, of course, that's here, which is an artifact. So this is, of course, of no importance, the 0 here of the lowest SaO2. Okay, so what are the diagnoses we would have in this case? We already said them, the rhinitis, snoring without, at least with this recording, without suspicion of obstructive sleep apnea.
allergic rhinitis.
And yeah, so these are the 4, if we want to say it like that. What would you go, in this case, if now that patient says, I want to be treated for the snoring, and you have, let's say you treat the nose and still there's snoring, would you go for drug-induced sleep endoscopy, or wouldn't you?
We can vote, do a voting.
Why? You said yes. Why?
Sometimes you see the drug do sleep endoscopy, things that are surprising. The sleep lab, the polysomnography. I have few cases that the polysomnography looks like normal, very limited apnea-hypopnea index, and on this DICE you see negative pressure, and you think it's not. There is no correlation between the sleep endoscopy and the polysomnography, and you are sure this patient has sleep apnea. You need to repeat the sleep lab or something. I have few cases.
I have a question to the audience, and then you, Olivier. What is something we didn't talk about at all in this case? Pardon? Body weight. We said he had a body mass index of 27, so yeah, weight reduction, of course, yes. But that would be regarding therapy. We are not yet there at the moment. But what topic, what theme didn't we address at all in this case? Epiglottis. You said alcohol, yeah. Now I want to point to something else. What do we have in body position? Right, left, no supine. If we now go for DICE, what is the typical body position for DICE? Supine position. So I just wanted to focus on the problem that this recording was without supine position. And that is something we have to ask, and we have maybe to repeat if we have a suspicion of sleep disordered breathing, because that may be not representative of what happens during other nights. Olivier?
Yeah, I think you're right. But to come back to that question on sleep endoscopy, I would like to mention my personal way of doing it is I would at first never think about sleep endoscopy in this case, because there is also, and maybe we can discuss on it, there's also in terms of cost effectiveness or in terms of reimbursement, there is an issue here that when we talk about primary snoring, taking into account also that there is an allergic rhinitis based on an allergy, that, for instance, in our country, I think it's difficult when we would perform this kind of examination on all of these patients.
It's impossible.
And on the other hand, I don't think it will give an extra value in the majority of them. I think we can talk about minimally invasive surgery. Radiofrequency of the palate is one example. The webbing can be treated very easily also with radiofrequency treatment. Probably when the medication is not enough for the allergy in the nose, you can maybe think of in the same time doing some radiofrequency at the turbinates. So I would advocate not to do a drug-induced sleep endoscopy at that stage. It's something else when you do a minimally invasive surgery and the patient is not treated. He's still complaining about snoring, and then I think the positional aspect and to do a sleep endoscopy, to do a proper workout then is very important. But a majority of the patients will be treated easily, I think, with minimally invasive surgery.
I completely agree.
I think you can get quite much information if you do flexible endoscopy and ask the patient to do a Maurer maneuver or try to snore. It can give you
Maurer maneuver.
some idea, and maybe that's the way when you can decide which patient deserve a DICE, sleep endoscopy.
That would be a cheaper examination, a Maurer maneuver.
Clinical examination at the first encounter, actually, part of your examination.
Yeah. We don't do the Maurer maneuver anymore because the patient has to work with us and we don't know how the patient does the Maurer maneuver. I can produce different types of airway obstruction during Maurer maneuver just because I use my muscles in a different way, and you never know what the patient is really doing, what you see during sleep. So that's why we dropped it completely. Yes, okay. Nasal provocation, anti-allergic therapy. So nasal treatment first and weight reduction, but as we discussed, radiofrequency, minimally invasive treatment of the soft palate would be our suggestion in this case. And no DICE. For the same reason as you said, if we do DICE in every snorer, it's 50% of the population. Impossible. the other thing if there's a failure.
So, as you know, we do DICE quite a lot, but what we would have
You're
done for this-
paid for it. We are not.
we paid for it, but what we would have done is we would have done the treatment for allergic rhinitis. Because the sleep study didn't show any sleep apnea, we would then offer them an oral appliance. We get paid for that as well. If
He has
the oral
only-
appliance then fails, or if they refuse, then we would talk to them about multi-level radiofrequency surgery and do the DICE before proceeding to that at the same sitting, so they don't have two admissions. And that works.
We
well.
didn't offer oral device in this case because there was only 5 millimeters of mobility, so maybe that's sufficient already. But he had also snoring in the lateral positions, so and simple snoring in 90% according to the data is linked to some palatal flutter. If there is no sleep apnea.
But
In
we've
sleep
also
apnea,
found
it's
that
different.
The oral appliance sometimes in some individuals does help with palatal flutter as well.
Yes, of course, it does. It does, but if it is in supine, holding your jaw, that's different. But here it was in the lateral position also, and if you cannot advance it, it would be only maybe 2 or 3 millimeters of advancement. So that's why we wouldn't. You have to talk about everything with the patient, and if he absolutely wants to try it and wants to pay for it, that's the patient's decision. Okay, let's go to the next. Maybe because we have only 50 minutes left and we have so many cases, so that I would say that we would skip that one, but go to this one. Number 3, 53 years old, almost normal weight, not like this person here. And the history was that there was snoring since childhood, mucosal dryness in the morning, headaches, apneas observed by the wife, and daily naps without feeling refreshed. And he had hypertension, diabetes, but no regular medication for hypertension whatsoever. Then for the sleep, loud and irregular high-pitched snoring, increase in the supine position, rarely falling asleep during monotonous work, no micro-sleep, that's his story. No trouble falling asleep in the evening and during night. The questionnaires were, the Pittsburgh Sleep Quality Index was normal, so no sleep disruptions, no problems falling asleep and maintaining sleep. Mild daytime sleepiness, so not in the pathological range, Epworth of 9. And visual analog scale snoring 6.4, so also not towards the 9 or 10. So for the ENT, some of the ENT exams, minor septal deviation, and you see far more airflow through the nose compared to the other patient. And in the 70-degree endoscopy, mild tongue-based hypertrophy. And in the throat, it looks like that. So if you just... But then 1 centimeter of protrusion when advancing the jaw. I didn't ask whether we do a sleep recording in that case because I assume that everybody is clear about that this is a case where we should have some sleep recording. Disease, some comorbidities, not clear sleepiness, but long time high-pitched irregular snoring, so that's something where the pre-test probability is high. You can debate whether outpatient or polysomnography. And now we have here a different recording, sleep stages here, position, right side, supine, the pink, oxygen here, CPAP pressure, but there was no CPAP, then hypopneas, obstructive apneas, and then some snoring, the green down here. So if you look at this graph, then what would be your primary impression of the diagnosis? OSA, very likely. Yes?
Positional obstructive sleep apnea?
It looks like, yeah. How that? Yeah. Here we have the supine position, and we have a lot of events when he is supine. And you see the increase being supine with a still for the whole night a normal range and some oxygen data and snoring index really high all the night. And a lot of limb movements which are, as it seems, not all the time linked to obstructive events. And that's how the patient looks like. So, well, what are we going to do with that patient? First time, it's not a failure, it's a first time. Mm-hmm. You would do DICE in that patient. Mm-hmm.
Consider anatomical variations because he has he's had this symptom for ever since childhood. And
for many years, yeah.
And he has gotten used to functioning that way. Maybe he doesn't even know that he is not functioning the way he should be. Mm-hmm. And it's been for such a long time, and all the others are more or less negative. And then, of course, he has this retrograde. Mm-hmm. So you could have the chance to see if there was something wrong there, even if the epiglottis was closing, and also you could see what a mandibular advancement would help him.
Mm-hmm. Good idea. Among the audience, who would talk about treatment options without talking about DICE at the first glance in this case?
I would perform also a DICE because there is a huge retrognathia in this patient. So
do you need a DICE then to see that?
No, but I would perform the DICE and send the patient to the dentist and perform the complete workup when I see a patient with retrognathia.
Olivier, you...
I would probably tend not to do a DICE and start a trial period with kind of positional therapy and see how far we get. It might end up doing a DICE, but it might end up having an even better than the 8.
What would be...
And then the snoring persists, and then maybe you can do a local treatment of the snoring.
What would be a negative part if you talk about positional treatment in this case? Maybe you remember? What would be something you should be doubtful about the compliance, the adherence to positional treatment in that particular patient? You want to say something? No? Look at the snoring here.
Mm-hmm. But therefore, I would tend to do a local treatment of the palate if really the apneas are gone with the positional therapy.
That's a good idea to go for positional treatment and add some snoring treatment.
Yeah,
as you said, 1 + 1 might be 3, so maybe combine treatment as a first glance. Yeah.
How resistant is this patient to like any kind of surgical intervention? Is he
how resistant?
Is he resistant to surgical intervention, or he?
No, he loves surgery. No,
well, I'm just because
he is a kind of a sadist. No, masochist. So he loves being hurt. No.
Right. Then a cephalometric analysis would be the.
Yeah, that's one thing.
Cephalometric analysis.
And the cephalometric analysis is here, so it proves what we thought, that there is a retrognathia of the upper and lower jaw. And the airway, the posterior airway space is quite small, and the height position is quite low. So all this points to a long face and a bimaxillary or maxillomandibular retrognathia.
If the patient is willing to undergo masochistic surgery, I think that's
what type of surgery?
If he is masochist and willing to undergo pretty aggressive surgical procedures, I think oromaxillofacial consultation is the next right step, I think. This patient.
Good. If we talk now about diagnosis, then we have this positional OSAS, maxillomandibular retrognathism. We have the continuous snoring, which isn't mentioned here. So first choice therapy, what I would recommend first, well, that's something again in this case where you can talk, of course, about these possibilities. And we were discussing them just now. But of course, why not trying CPAP? Automatic CPAP. You can also use automatic CPAP. Depends on the patient's preference. And that's something which is very important for us, I think, compared to the pulmonologists, that we can offer different things to patients, not only CPAP in all of them. Any comment on that, or?
So we would have asked about CPAP, but because he didn't have much daytime sleepiness, we find the compliance and adherence is very poor. We would have gone for a mandibular advancement device.
If the patient wants CPAP, I'm happy to try it. And there are
Especially if
patients like that who use CPAP for decades, and they're fine. Yeah.
We would have gone for the mandibular advancement device first. If that failed, then a DICE and maybe referral to maxillofacial surgery.
Again, that's a patient who may select his treatment, his first choice treatment, together with us. Yeah.
Maybe, Joachim, I think the suggestion of an oral appliance or CPAP is good, is worthwhile, but I think in many countries it would not be reimbursed because his HI overall is only 8, if I remember correctly. So that's another, I think, a drawback in the discussion with the patient. I fully agree that he needs to know about the option of MMA surgery from the first time you discuss on treatment. But again, I would advocate to have the less invasive treatment options. It's a clear POSA. Also, propose to the patient in the first stage of the treatment. And there's a danger in this case, I think, that when you would do an MMA, that he might have a residual POSA after surgery. There is some data that this is a risk patient to have some POSA afterwards. So I think to have a positional therapy anyway throughout the whole of the procedure of treating the patient is probably worthwhile. It's beneficial.
So we've only got 5 minutes left. I would like to give the audience an opportunity to ask the panel any questions, anything we haven't covered. And if you haven't got any questions, then perhaps one more case. So there are some questions. Let's have some discussion questions first.
I heard about this barbed wire technique, but you didn't speak about it. Can you give some information on that technique? When do you use it and how successful is it?
It is a recent technique, and it is not yet, I would say, out of the experimental stage. There are some Italian colleagues who started doing that, and at the moment there is no publication regarding the isolated use, as far as I know. It's only in together with other interventions, tongue-based, robotic surgery, whatever. So I would not recommend it to be used as a kind of a standard of treatment.
And when you feel, as an experienced team, about the pathophysiological idea about it, what do you think about it? I saw the videos, it looked... Wow.
Yes, well, new, during the last decades we have seen, that's the problem I have, we have seen many videos looking very nice, and some of them remain and prevail over a certain number of years, and others are not found anymore.
Comment on that. It is widely used in facelift techniques to bring, if you repair the tissue, to have it in a position. You know, there are barbed wires like that. Yeah. So if you make like that, it stays like that. Yeah. And can you imagine how it is in your throat? Do you make like that and it stays like that? It gives you a lot of tension, and in general it is a resorbable suture. So someone in 6 weeks time or so, it will dissolve. Otherwise, you maybe have problems with swallowing for the rest of your life. Okay. So it's just
under evaluation.
That's enough. That's enough for me. Yeah.
No, it may be.
I was just wondering how you think about it as experienced surgeons.
It may be a good option.
To be fair, the Italians have actually advocated it. Salamanca, Sorrenti, and Vicini have written lots of papers on relocation, and they've shown the dimensions of the nasopharynx and oropharynx improve. I personally don't have any experience, but I would agree that long-term follow-ups are required. Randomized control studies are required.
Is it about the barbed or is it? Oh.
I just came from Professor Vicini. I was there like about 3 weeks, and he's doing the barber technique. It looks very simple. Use the wire that has a small knot on the wire that it cannot move, and he use it very nicely, and the results, as is said, are very good results. So,
But they are all combined surgeries.
Yeah,
They are
it's
all
multi-level,
combined
it's
surgeries, so you
multi-level.
never know what is due to that part. I also did it 2-3 times in cases where everything looked normal and I didn't want to cut out anything. And at the end of surgery, it looks nice in a certain way, but I don't feel happy to advocate to say, oh, that's a brilliant treatment, because we don't know yet. It may be good for certain indications, but I don't know yet.
Well, usually when the surgeon doesn't feel good about it, then it's usually not a good technique. So one technique that you felt really good about, I remember that you said 3 years ago that the hypoglossal stimulation was going to be the new cochlear implant.
Yes, I'm sure we did in Mannheim now 100 of this, and I'm sure that
120.
In Brussels and in Antwerp they did also.
So have there been any new improvements on the device, or is it coming soon that it's going to be even better?
There is the Inspire will be starting the 2nd of May, will be available in Europe as an MRI compatible device and smaller. That's already available in the US, but the European authorities took a long time to approve. And
there's also the bilateral implants with the Nixoa.
that is under investigation. It's pre-marketing. So there will be maybe, if the system prevails, there will be bilateral stimulation possible, and the open loop technique without respiration sensor, IMTHERA. There is a big prospective randomized trial almost at the end of recruitment, as a 5-year follow-up study, randomized control trial. And we will probably then have more information about when to use which type of hypoglossal nerve stimulation. There's some overlap, but there are also some differences.
And when is going to be the time that the insurance companies cannot say no to that kind of treatment anymore, based on the costs versus the effect?
That's a question I cannot answer. They always can say no, depending on your country.
In the UK, the NICE guidelines are coming out, and they're recommending that it can be done at certain centres, but properly controlled and monitored and audited. So I think in the UK it's going to be a long time. We haven't done any as yet, but they already looked at the American data, the Stroller paper, the 5-year reports. And
we just published the 5-year data of the STAR trial, and it stays stable.
So consistency is there, long-term improvement is there.
But not everybody, we are at 80 to 90% success rate with the selection, but not everybody.
Okay, I think we should break up. I'd like to thank the audience for your participation and the panel for their lovely presentation.